and remind you that we are in our last hours of spring of 2023, and at exactly 10:58, summer will begin. So happy first day of summer, happy ending of spring. And I hope it stays this cool, calm, and collected. I thought it was a really wonderful spring. Also note that today is it's the summer solstice, so this is the longest day of the year. This conference is going to be one of the, not longest, but I think one of the best ones that you're going to hear in a long time. It's really wonderful to be talking about childhood immunizations. But I also want to start with just a little bit of information about the Department of Health. You know, our mission is to protect the public health, promote healthy communities, and continue to improve the quality of healthcare in New Jersey. And our vision is that we will ensure that all New Jerseyans live long, healthy lives and reach their fullest potential. And certainly vaccines are among the most important ways that we can help our children to truly reach their potential and to be spared these childhood infections. I think it's amazing that here in 2023, we now have 17 diseases for which routine immunization is recommended. That starts right from birth with hepatitis B, then rotavirus, diphtheria, tetanus, pertussis, Haemophilus influenza type B. You notice that I have white hair. I remember taking care of children with Haemophilus influenza meningitis. It was horrible. In my short career in medicine, we saw truly the end of Haemophilus meningitis. I was amazed when my residents now go through their entire residency without seeing a single case of Haemophilus disease, which is truly a wonderful thing that I've been able to watch. Pneumococcal disease, polio, COVID-19, influenza, measles, mumps, rubella, varicella, hepatitis A, human papillomavirus, and the meningococcus. And then, of course, we have a number of other vaccines that are licensed in the United States that we don't talk about very often that are recommended in certain situations. Dengue, rabies, yellow fever, cholera, adenovirus, anthrax, BCG, smallpox, mpox, Ebola, Japanese encephalitis, plague, typhoid, tick-borne encephalitis, and just recently we have a vaccine now against respiratory syncytial virus, only recommended for adults at the moment and older adults, but coming very soon for pregnant women and hopefully soon after for children. You know, it's been a wonderful thing to watch new vaccines come into play and to watch these diseases disappear. But even since the beginning, there's been lots of misinformation and disinformation. I don't know, it seems that vaccines just make people a little bit wacko. And even from the start, back in 1802, the cartoonist James Gilroy drew a cartoon of people having cows coming out of their bodies because they had received the cowpox vaccine. So vaccine misinformation is not new. Disinformation is not new, but it does seem to be particularly annoying, and it really does make our lives a little more difficult. And it makes it very important that we figure out how to deal with this information and misinformation and how to kind of reframe the talks. And today we're going to give you some of those tools to combat the misinformation, but also we're going to give you a lot of information just so that you are more informed about a variety of vaccines. We're going to start with some information about really a deep dive into the impact of COVID-19 pandemic on routine immunizations across the lifespan. So not only children, but also adults have gotten less vaccines during the pandemic. Then we'll hear about COVID-19 routine immunizations and vaccine hesitancy, framing the conversation. This idea of framing, I think, is really an important new concept that I know you're going to value the information about that. And then we'll take a break but soon after we'll tackle overcoming vaccine fatigue to protect population health, immunizing our communities, a panel discussion, and then building immunity, building confidence, how New Jersey is leading immunization initiatives. So I think it's going to be a fantastic day. And without further ado, I'm going to turn it back over to Kendra Gillian, who's going to introduce our first speaker.
Thank you so much, Dr. Fisher, for a wonderful welcome. So now I'm going to turn it over to our first speaker, Kathleen Holmes. But while I do that, let me just pull up her slides. A second here. Okay. So before we begin, I just want to quickly introduce Kathleen. Kathleen is a senior public health analysis in the Chief Medical Office in the Immunization Service Division at the Center for Disease Control and Prevention. She coordinates Let's Rise, which is the division initiative to understand and address pandemic-related declines in routine vaccinations. Prior to joining the Immunization Services Division, Ms. Holmes spent a decade working in various global health positions at CDC, including the Division of Global HIV and AIDS. So Kathleen, please take it away.
Great. Thanks, Kendra. I just want to check, are you able to hear me?
Yes, I can hear you.
Wonderful. Well, thank you for the kind introduction, and good morning, everyone. I'm excited to have the opportunity to be here with you today. And my apologies for the technical difficulties this morning in not being able to join you via Zoom. Kendra and I will do our best to proceed with Plan B and do this via phone and have her advance my slides. So over the next 30 minutes, I'd like to summarize our latest understanding of the impact that COVID-19 had on routine immunization coverage nationally and in the state of New Jersey, and provide an overview of CDC's Let's Rise initiative to get U.S. residents back on track with their routine vaccinations. Next slide. Between 2019 and 2021, global immunization coverage fell by 5 percentage points from 86 to 81% worldwide. This is the largest sustained decline in childhood vaccination in approximately 30 years. Similar to global trends, we have seen a concerning decline in both childhood and adult immunizations in the United States that began in March of 2020. Soon after the national emergency was declared, vaccine for children vaccine orders decreased significantly. By mid-April 2020, orders for non-flu vaccines had declined by 3 million doses, shown in the solid blue line. By this time, measles-containing vaccines had decreased by over 400,000 doses. Routine vaccine orders and administration have subsequently rebounded since this time, but unevenly. Next slide. At CDC, we are monitoring the impact of the pandemic on vaccination coverage in the U.S. by measuring differences in vaccine orders, claims rates, immunization records, and self-report survey data prior to and during the pandemic. We are taking into account all available data to better understand the full picture of what happened. Next slide. One way that we evaluated the impact of the pandemic on routine vaccination is by monitoring our vaccine orders for the Vaccine for Children's program, known as VFC. The VFC program provides vaccines at no cost for children who would otherwise not be able to afford vaccination. In the US, about 50% of children receive their vaccines through the VFC program. One of the largest advantages of vaccine ordering data is that it's possible to get this information very quickly, and thus provided an early signal for what was going on with the pandemic. We are currently looking at ordering data monthly, but in the early parts of the pandemic, we were looking at it even more frequently to assess changes in ordering trends. So using FY 2019 as our baseline, we see that total VFC orders decreased by 14% in FY 2020. Since then, VFC vaccine orders have steadily rebounded. Year-to-date orders for FY 2023 are close to the same time period as FY 19 and now exceed pre-pandemic levels for all childhood vaccines except for HPV. Ordering data, however, has certain limitations and is not an exact proxy for administration. Next slide. So this slide shows data on vaccine coverage by age 24 months for children born between 2011 and 2019, using data from the 2021 National Immunization Child Survey. The 2021 NIS Child surveyed approximately 48,000 children born between January of 2017 and May of 2020. Parents completed a telephone survey and vaccination information was obtained by mail, a mailed survey from the child's healthcare provider. Overall, childhood vaccination coverage has remained high and stable for children even after the pandemic began. Analysis by jurisdiction revealed that just as many, if not more, areas where coverage increased rather than decreased during the pandemic. Next slide. New CDC data summarized in an MMWR and online report did not identify any consistent or persistent declines in vaccination coverage associated with the COVID-19 pandemic nationally when comparing young children who reached milestone ages prior to the pandemic to those reaching the same ages during the pandemic. We found temporary declines in MMR and varicella vaccine coverage among children that turned 13 months old in March and April of 2020, but these birth cohorts caught up by 24 months. Next slide. We are concerned, however, by declines in routine vaccination coverage among certain groups of children and vaccines. We found that coverage with the combined 7 vaccine series by age 24 months decreased 4 to 5 percentage points among children living below poverty or in rural areas. As you can see, for the 7 vaccine series among children living in poverty was 60% and 64% coverage among children living in rural areas in 2021. This is 6 to 10 percentage points lower than the national average. We also found that disparities widened during the pandemic among children living in rural areas as compared to those living in urban and semi-urban areas. Next slide. Disparities in routine childhood vaccination coverage that existed prior to the pandemic also continued to persist during the COVID-19 pandemic. In particular, we found that children with no insurance were over 8 times as likely to be unvaccinated by 24 months as were privately insured children in 2021. While drops in coverage by sociodemographic characteristics were also observed among children that reached 8 and 19 months of age when the pandemic began, none of these drops were statistically significant by 24 months. So while disparities continued, we did not see disparities widen by race, ethnicity, or insurance status during the pandemic. Next slide. So here you can see vaccine coverage by age 24 months for children born between 2011 and 2019 in New Jersey. Vaccination coverage for New Jersey is delineated by the solid purple line, and national coverage is noted by the solid blue line. Children to the left of the red dashed line turned 24 months old prior to the start of the pandemic, and children to the right of the red dashed line turned 24 months.
Can we switch the slide?
Are we?
There we go.
Should I continue? Okay. So children to the left of the red dashed line turned 24 months old prior to the start of the pandemic, and children to the right of the red dashed line turned 24 months during the COVID-19 pandemic. So as you can see on this graph, the 7 series vaccine coverage for New Jersey has been historically at or below national coverage rates for the 7 years prior to COVID, with the exception of 2015. Next slide. So in taking a closer look, we can see that similar to national coverage, average 7 series vaccine coverage remains stable in New Jersey among 2-year-olds during the pandemic. You'll note on the right that changes in coverage observed were not statistically significant. Next slide. So moving from young children to kindergartners, the impact of the pandemic was more widespread on routine immunizations among 5 to 6-year-olds. Next slide. Each year, we receive state-level aggregate data related to vaccines required for school entry of kindergartners, collected by immunization programs in schools. Relevant factors such as vaccines required, exemptions allowed, grace period, and information on other policies are also collected. For the 2021 to 22 school year, we received state-level aggregate data from 49 states in the District of Columbia. We found steady declines in national vaccination coverage among kindergartners for 2 school years in a row. Declines were for all vaccines and in a majority of states. For the 2021 to 22 school year, nationwide coverage of MMR, DTaP, polio, and varicella vaccines among kindergartners was approximately 93%. However, MMR coverage ranged from 78 to 98% across the 49 states and DC. This is the lowest that we've seen kindergarten vaccination coverage in the last decade, and translates to more than 275,000 children who entered kindergarten during the pandemic who were not up to date with their vaccinations and potentially at risk for severe disease. Although vaccination rates remain high overall, we are concerned by this downward trend. Next slide. We also looked at provisional enrollment and grace period status for kindergartners in 27 states. The main thing that I want to draw your attention to here is that exemptions remain fairly stable, around 2.6% when comparing the most recent school year to the 2019 to 2020 school year. However, the number of students enrolled under grace period or provisional enrollment increased by nearly 1% nationwide during the same period, and by as much as 8% in some states. And while there's been nearly a complete return to in-person learning, immunization programs continue to report COVID-19 related impacts on their ability to accurately assess kindergarten vaccination coverage. Next slide. So here's a more detailed look at kindergarten vaccination coverage for the 2011 to 2012 school year through the 2021 to 22 school year in New Jersey. As you can see, kindergarten coverage rates prior to the pandemic were stable and high, above 95% coverage over the past decade, with the exception of the 2014 to 2015 school year. MMR coverage estimates for kindergarten vaccination coverage, however, fell 2 years in a row in New Jersey, cumulatively declining by 1.8%, from 95.9% in 2019-2020 school year to 94.1% coverage during the 2021 to 22 school year. Declines in New Jersey are similar to what we saw nationally. Next slide. Non-medical exemptions at 2.6% and provisional enrollment of 1.3% for the 2020-2021 school year and the 21-22 school year remained on average fairly stable as compared to the 2019 to 2020 school year. Next slide. So the good news is that even with continued declines in coverage, most states, including New Jersey, can still achieve target coverage. As an example, here's the potential achievable MMR coverage by state. Potential achievable coverage is estimated as the sum of the percentage of students with up-to-date MMR and the percentage of students without up-to-date MMR and without a documented vaccine exemption. When looking at the stacked bars, the dark blue portion are MMR coverage. And the light blue portion are the percentage of kindergartners not documented as having 2 doses, but also not exempt. Based on the reported data from the 2021 to 22 school year, 5.9% of kindergartners in New Jersey did not have documented vaccination, but just 2.6% had a documented exemption. This means that the gap of at least 3.3% of kindergartners did not have a documented vaccination for MMR, but also did not have a documented exemption. If all non-exempt kindergartners were fully vaccinated, MMR vaccination coverage could reach at least 97.4% in New Jersey. So enforcement of vaccination policy remains one important way of strengthening vaccination coverage. Next slide. For adolescents age 11 to 12, the Advisory Committee on Immunization Practices recommends the following routine vaccinations: Tdap, HPV, and meningococcal ACWY. Next slide. Unlike all other VFC orders, HPV is the only vaccine in which provider orders as of March 2023 have not yet rebounded to pre-pandemic levels. As you can see here, orders began rebounding after an initial drop of 24% in FY 2020 and stagnating around 10% lower in FY 21 and FY 22. As of last month, provider orders were 7% lower in FY 23 as compared to the same time period in FY 19. Next slide. So this slide shows the trend in vaccination coverage among 13 to 17-year-olds between 2006 and 2021 using data from the National Immunization Teen Survey. The 2021 NIS Teen surveyed approximately 18,000 teens who were born between January of 2003 and January of 2009. Vaccination coverage estimates are based on provider-reported vaccination histories and include any vaccines administered before the 2021 NIS teen interview date. The cumulative percentage of adolescents vaccinated by age in years 12 to 17 was assessed and stratified by year of birth. Overall, men ACWY and Tdap vaccination coverage, which are represented by the red and blue lines, remained high and stable. However, when we took a closer look at the data by birth cohort, we did see some impact of the pandemic on meningococcal and Tdap vaccination among certain age groups that became eligible for the vaccine during the pandemic. Specifically, vaccination coverage dropped 4 to 5% among teens that were born in 2008. HPV vaccination coverage for both first and second dose completion and series completion, represented by the purple and green lines, increased during the pandemic as compared to pre-pandemic coverage among 13 to 17-year-olds. However, we do not have data on the impacts of HPV coverage on younger adolescents 11 to 12 years of age. This may account for discrepancies in ordering and coverage data. The 2022 NIS teen data, slated to come out later this summer, will provide additional information about pandemic impacts on adolescent vaccination. Next slide. Next, we'll take a look at adult vaccination. Next slide. While adult vaccination has slowly improved over the past decade, as you can see on the table on the right, vaccination coverage fell substantially short of the Healthy People 2020 targets, with the exception of herpes zoster prior to the pandemic. Thus, for adults, the goal is not only to catch up adults that delayed vaccination during the pandemic, but to continue to increase uptake above pre-pandemic levels going forward. In regards to the pandemic's impact on adult vaccination coverage, we found it hard to assess because there were also a number of changes in ACIP recommendations during the same period, which might have changed adult or provider vaccination behavior. So it's hard to attribute changes directly to the pandemic. Next slide. With that said, I'll present claims data that shows changes that occurred during the pandemic. Here we see a large initial drop-off in claims among Medicare FFS beneficiaries 65 years and older for 4 vaccines: PCV 13, PPSV 23, Tdap, and recombinant zoster. You can see the light blue bars for the time period from March to July 2020 are significantly shorter than the dark blue bars for the same time period in 2019 across all 4 vaccines. Declines were similar across all race and ethnicities. Since this time, preliminary analysis indicates that Medicare claims rates have partially recovered, which you can actually see for PPSV 23 by June of 2020. Next slide. The drug manufacturer GSK and the health information technology company IQVIA also analyzed adult vaccination claim data, which they published online. They found that national vaccination claims across all markets declined in spring of 2020 and remained below pre-pandemic levels throughout 2020 and 2021, except for a brief period in the fall of 2020. They found that declines in claims were widespread across all vaccines, race, ethnicities, and payment types, with some variability by location. GSK estimates claims dropped by a combined 18% in 2020 and 2021 as compared to pre-pandemic claims levels, which is equivalent to an estimated 12 million adult vaccine doses missed. It appears that claims are beginning to rebound in 2022 as compared to the prior year. However, they remain approximately 9% lower than claims rates in 2019. Next slide. GSK estimates that adult vaccine claims in New Jersey declined by 7% in 2020, 18% in 2021, but have rebounded to above pre-pandemic levels in 2022. New Jersey still has an estimated deficit in claims between January of 2020 and September of 2022 of approximately 16%, which is equivalent to an estimated approximately 100,000 adult vaccine doses missed. Overall, while adult vaccine claims rates fell in New Jersey, declines in claims were much smaller and have recovered faster than adult claims rates nationally. Next slide. And whereas CDC found that adult flu vaccination coverage remained stable or increased among adults during the pandemic, we found from an internet panel survey conducted in April of 2022 that maternal vaccination was an exception. Both flu and Tdap vaccination coverage declined among pregnant women during the pandemic. Here you can see Tdap coverage dropped during the 2021 to 22 flu season by approximately 10 percentage points among pregnant women. Next slide. Similarly, the study found that flu coverage significantly decreased by 8 percentage points over the course of the pandemic, steadily declining from 57.5% during the 2019 to 2020 flu season to 54.5%, and then to 49.6% during the 2021 to 22 flu season. Both Tdap and influenza vaccination coverage decreased most among white pregnant women, and this is the first time coverage has declined among this group. Next slide. So we know that the pandemic caused disruptions in healthcare services and impacted routine vaccination coverage among certain groups. We also are looking into whether the COVID-19 pandemic impacted attitudes and beliefs towards routine vaccines. Next slide. Prior to the pandemic, more than 3/4 of American parents and caregivers expressed overall confidence in routine childhood vaccination, and 95% of kindergartners were up to date with their vaccinations. Next slide. In our preliminary scan of published literature, we found that independent survey data suggests that overall public attitudes around routine vaccines remained stable during the pandemic. However, vaccine confidence is waning among a minority of adults. As many as 1 in 5 parents and caregivers reported that their confidence in routine vaccination for themselves or their children decreased during the pandemic. And support for school vaccination requirements has also decreased by approximately 10 percentage points, which amounts to around a quarter of Americans who now support the right to send their children to school without being vaccinated. Next slide. So the full impact of the COVID-19 pandemic on routine vaccination coverage and attitudes for both children and adults will take time to determine. While we continue to investigate, we are prioritizing getting everyone caught up on routine immunizations that were missed or delayed during the pandemic. We know that if we don't take action to catch up on routine vaccinations now, there will be more challenges in the future. Next slide. In our response to pandemic-related declines in routine immunizations, CDC launched a new initiative, Let's Rise, which stands for Routine Immunizations on Schedule for Everyone. Let's Rise incorporates and builds upon our Let's Play Catch-Up campaign that was launched in 2021 and really focused on encouraging parents to catch up children 3 to 6 years of age on routine vaccinations. Let's Rise broadens these efforts to support catch-up across the lifespan. The goal of Let's Rise are noted at the bottom: to understand the size, scope, and cause of declines and monitor progress towards recovery, to devise an evidence-based strategy and operational plan to better direct CDC resources to get routine immunizations back on track, to equip partners with evidence-based tools and resources, and to continue to share data and insights on trends in routine vaccination rates in order to target communities that fell behind on routine immunization. Next slide. Well, Let's Rise includes communication activities. It is not a communication campaign. Rather, it's an 18-month framework grounded in data for addressing pandemic-related declines in routine vaccinations. Efforts bring together and make readily available relevant data and actionable strategies to ensure that we are all working from a similar playbook to get Americans caught up with their routine immunizations. We have not received any additional funding for this effort, so it's really about prioritizing and targeting existing resources and activities to ensure that they include communities that have fallen behind on their vaccinations. And in some cases, when existing efforts are not sufficient, better understand what is needed to strengthen routine immunizations in those communities. Next slide. Here you can see a summary of partners with whom we hope to collaborate on catch-up, including health departments, healthcare providers, public health and community partners, schools, and daycare centers. Next slide. So what is CDC doing to catch up or to support catch-up? Next slide. In addition to partner engagement, we also recently reactivated our paid digital Let's Play Catch-Up ads. These ads seen here leverage paid media channels to deliver our catch-up messages across digital touchpoints through highly targeted tactics, aiming to keep routine child vaccination top of mind among parents of children ages 0 to 6 years. This campaign will run through June 2023 in select markets, including New Jersey, and other jurisdictions noted at the bottom of the slide. Next slide. Planning is also underway for a nationwide back-to-school Let's Play Catch-Up campaign, which will run from July through September and will focus on encouraging parents of school-aged children to stay up to date on their children's vaccinations. As a part of the back-to-school campaign, we are planning to put out 2 calls to action, one for healthcare providers and the other for school leaders, encouraging them to prioritize catch-up and providing ways and resources to take action. In addition to CDC resources, we are also working with Public Health Foundation to create partner toolkits to share actionable resources, those that can be downloaded, adapted, and used by partners for catch-up. And finally, we are offering jurisdiction health departments technical assistance to come alongside and support their ongoing work to get Americans caught up on their vaccinations. Next slide. So here you can see some of the CDC back to school communication assets that we're developing. We plan to make these available on our website in both a branded and unbranded form in July, and we encourage our partners to use them as helpful. Next slide. Some of the strategies that we know work to strengthen vaccination rates are noted on this slide. I'm not going to go over all of them in detail during this presentation, but we'll share the slides afterwards. At a high level, some of the evidence-based strategies that we know work well to increase vaccination coverage include making vaccines accessible and convenient, employing reminder recall systems, building trust in vaccines, health systems, and vaccine administrators, employing clear and consistent communication, and making strong vaccine recommendations. Nothing about this initiative is new or innovative. It's really about making sure that we are getting back to doing what we know works well, as everyone has more capacity to focus on recovery rather than emergency response. Building upon the partnerships forged during the COVID-19 pandemic, and using data and insights to reach communities that fell behind on routine immunization. Next slide. For more information about Let's Rise, you can check out our Let's Rise webpage, which includes evidence-based tools, resources, and communication assets that can be leveraged for this work. The URL for this webpage is noted on the bottom of the slide. Next slide. So in summary, the COVID-19 pandemic caused disruptions in routine health services, including vaccination. High rates of childhood vaccination and low rates of adult vaccination were both initially made worse by the COVID-19 pandemic. Nationally, pandemic-related impacts on childhood vaccine coverage appear to have been temporary. Rates remain stable among young children 0 to 2 years of age and adolescents 13 to 17 years old. Rebounds in vaccine ordering and administration are insufficient to catch up everyone that missed a vaccine dose in 2020, 2021, and 2022. In New Jersey, vaccination coverage among 2-year-olds remained below the national average, and kindergarten vaccination coverage declined during the pandemic and has not yet rebounded to pre-pandemic levels. Adult claims rates are rebounding, but have not yet completely recovered. Next slide. So before concluding, I'd like to acknowledge the tremendous contribution that colleagues across the Immunization Services Division have made. This presentation reflects their work both in understanding and developing a strategy to address pandemic-related declines in routine vaccinations. Next slide. So thank you again for the opportunity to present, and I'm happy to answer any questions that you have.
Thank you so much, Kathleen, for such a wonderful presentation. We do have a few questions here for you. So let me stop sharing here. Okay. So are vaccinations no longer required before children start school, or are people finding loopholes to not get their kids vaccinated?
Yeah, so vaccination policies are set by states, and all states still have required vaccinations for school entry in kindergarten and also for middle schoolers, typically in 7th grade. And the requirements really have not, at this point, changed. Individuals continue to be able to request an exemption. But as I mentioned, we actually did not see rates of exemptions change during the pandemic as compared to pre-pandemic exemption rates.
Okay, great, thank you. I have another question here. For the Let's Rise campaign, what resources and strategies will the CDC equip health departments and partners with? How can health departments and partners get involved with the campaign?
Yeah, that's a great question. So the types of resources right now on our website, we primarily have compiled different resources from across CDC that are related to strategies that we know work well to strengthen routine vaccination. So it's really meant to be a one-stop shop so that you don't have to be looking across different CDC web pages to find those resources. And resources include strategies, they include communication assets that can be, again, downloaded and used by partners. We also have a number of CDC toolkits, and we're working again with another partner currently to put together a partner toolkit that brings together many of the different resources that partners have created that can be utilized by others in kind of a drop-and-play fashion. And those include communication assets, letter templates, robo messages, many different types of resources. And we hope to have those up and on our webpage shortly.
Okay, great.
And really, as far as in regards to health departments, one thing that we are doing is we are reaching out and meeting with health departments in jurisdictions where there were declines in the greatest declines in routine immunizations. And again, because we don't have funding for this initiative, we're really trying to look internally at CDC and looking at the expertise that we have in-house and hoping to come alongside and provide technical assistance to health departments as needed and helpful to support this work.
Thank you, Kathleen, for that. I have another question here. If you do not have a child's vaccine record, will giving them the same vaccine twice cause harm?
That I would have to defer to our doctors and my other colleagues at CDC to make sure that I provide accurate information. So I can get that information and provide that to you afterwards, Kendra.
Okay. Thank you.
Actually, I'd be happy to take that one. In general, giving an extra vaccines does no harm. There are rare exceptions. You don't want to be giving more than about 10 tetanus shots. But for the vast majority of vaccines, the extra dose is not harmful.
Thank you, Dr. Fisher, for that. Okay, so we have a few more minutes for additional questions. Where are resources to get shots for all in place of going to expensive doctor office visits?
Yeah, so for many children, if they may qualify for the Vaccine for Children's program. As I mentioned, that supports vaccinations for about 50% of children. And so those vaccines are free to parents that could not otherwise afford them and whose children are part of Medicaid and CHIP programs. In addition, I will also maybe let Dr. Fisher, you may have some additional information about additional places. I know that there are community health centers, FHQCs, local health departments as well that provide vaccination. But maybe I'll turn it over to you for additional thoughts.
No, I would absolutely agree with you. No additional.
Okay. Do we have any data on COVID-19 related to percentage of infections with and without COVID-19 vaccinations?
Again, I can go back and follow up on that question. I don't have that data currently.
Okay. And I will make record of some of the questions that are asked, and if, when Kathleen provide those information, I will share it with those that are asking the questions. Okay. We have 2 more minutes. Okay. For children coming from other countries with incomplete vax records, is it okay to just administer the age-appropriate vaccines needed during the visit?
Dr. Fisher, I may turn that over to you if you have thoughts on that one, or I can follow up on my side.
Thanks, absolutely. Yes, that is absolutely appropriate. If they do come with a vaccine record that where the dates make sense and you think it's a reliable record, you absolutely can give them credit for the ones that they received. It's also, if requested, you can also get titers for certain of the vaccines, but you don't necessarily want to do that because remember, even if someone has a titer, that only tells you they're protected at this moment in time. So you still would like to give them whichever vaccines they're due for. So a rather long answer to a short question, but the short answer was yes.
Thank you, Dr. Fisher. All right, we have time for one more question. Since vaccine hesitancy is often due to concerns about vaccine safety, will the CDC be conducting additional studies on the current vaccine schedule to address these concerns?
So we do ongoing monitoring for vaccine safety, and we have for many, many years. And so that monitoring will continue. And for routine vaccinations, there, are decades of data to show that they are both safe and effective. For newer vaccines such as COVID, of course, or for all vaccines, data safety monitoring will be ongoing. And if there are any safety signals, those will be taken seriously and looked into.
Okay, great. Thank you so much, Kathleen, for a wonderful presentation. I have other questions, but unfortunately, we have to stop here and turn it over to Dr. Schwab. Again, thank you, Kathleen. Please use the Q&A box if you have questions. That way your questions do not get lost in the chat box. So now I'm going to turn it over to Dr. Schwab. And while he's getting ready to share his slides, I'm going to briefly introduce Dr. Schwab. Okay. So Dr. Schwab is an associate professor of pediatrics at Rutgers, New Jersey Medical School in the Division of Primary Care. He sees patients in the general pediatric outpatient practice at University Hospital in Newark, New Jersey, and he teaches medical students, nurse practitioner students, and residents at New Jersey Medical School. Dr. Schwab received his MD degree from UMDNJ, New Jersey Medical School, and MPH from UMDNJ, School of Public Health. Dr. Schwab, please take it away.
Thank you very much, Kendra. Let me see if I'm showing these slides properly.
Yeah, if you go all the way to the top, to the left, you can advance it to, yeah, there you go.
Okay, and are you seeing just the slides?
Yes.
Great. Okay. All right, thank you, and good morning to everybody. I really appreciate this opportunity to speak to you this morning. First of all, I'd like to add my thanks for our first speaker for her excellent presentation, which really set the foundation for a lot of this talk. Some of what I'm going to say will overlap with what she's already spoken about, but as with a lot of the work that we do with vaccines and public health and education, I think that repetition and reinforcement go a long way to increasing our goals. So forgive me if I repeat anything, but I think it should hopefully be valuable to you. So my topic this morning is on vaccine hesitancy. So we're going to look a little bit more practically on the types of things that we can do on several levels, both as individual practitioners working with individual patients and in our roles as working with populations in public health to overcome vaccine hesitancy and increase uptake of vaccines. First of all, I do have no conflicts of interest to report, and I'd like to acknowledge some of the people that have helped me and some of the organizations that have helped me with my work on vaccines, both in clinical practice and in academics. So first of all, the American Academy of Pediatrics and our local New Jersey chapter are invaluable to all of us working with children to increase our goals. The National Immunization Partnership with the Academic Pediatric Association has a lot of good information on immunizations that I've used and worked with over the years. And then I work closely with the Essex Metro Immunization Coalition here in the greater Newark area. It's a coalition within the Partnership for Maternal and Child Health of Northern New Jersey. And I think is a very good example of the kinds of local organizations that each of us can get involved with to try to further our efforts for immunizations among children and the families that we work with. So I'm going to define and describe for you what vaccine hesitancy is and explore some of the reasons that parents and families have for being vaccine hesitant, and then spend the second half or more of the talk looking at strategies for countering vaccine hesitancy in our families and population. So first of all, why is this important? I don't think I need to spend too much time with all of you, because I think this is probably a very committed audience that knows that vaccines and immunizations are important. But we know that vaccines have successfully eliminated or dramatically reduced the incidence of many infectious diseases in the United States. And yet, despite the vaccine availability, as well as our routine recommendations to vaccinate everyone who's eligible, there are still about 42,000 adults and 300 children that die each year in the United States from a vaccine preventable disease. And so routine immunizations of all children born in a single year can prevent 20 million cases of disease, can reduce direct healthcare costs by about $13.5 billion, and can save about almost $70 billion in total societal costs. Vaccine hesitancy, as defined by the Strategic Advisory Group of Experts on Immunization, or SAGE, which is a working group of the WHO, refers to a delay in acceptance or a refusal of vaccination despite availability of a vaccination service for that individual. We know that it's a complex and context-specific problem that varies across time, place, and among the individual vaccines. And so it's really thought of more as a spectrum rather than a yes, no kind of a thing. And that's why it's really referred to more as hesitancy, which implies a movement rather than a refusal, which is a hard stop. It's influenced by several factors, and some of these include complacency, which refers to a person's perceived need or the perceived value that they place on vaccine and vaccination services. It's influenced by convenience or issues related to access. How easy is it to get a vaccine? And so how motivated do I need to be to acquire a vaccine in the place where I live and with the resources that I have? And it's influenced by confidence, both trust of the vaccine and the system that produces and licenses and recommends vaccines, as well as, and probably most importantly, confidence in the provider who's offering that vaccine to the patient in the moment. And we'll look at all of these as we go through the talk. Vaccine confidence refers to the belief that vaccines work, that they're safe, and that they're part of a trustworthy medical system that is working to further the care of the individual. And it refers to the trust that patients, parents, and healthcare professionals ourselves have, both in the recommended vaccinations themselves, in the providers and the system that's in place to administer these vaccines, as well as in the processes that lead to the manufacture, licensure, and recommendations of the schedule that we're asked to follow. And what we're trying to do is increase confidence in the vaccines themselves and in the system so that people will be willing to take them. So the CDC reported in 2018 that while overall childhood immunization rates remained high during 2012 to 2017, there continued to be an increase in the number of children with no vaccines at age 24 months. And so this problem has been growing. It predates the COVID pandemic, which many people saw as kind of an impetus to look at recommitting to our efforts to engage patients in receiving routine vaccinations. But it's been going on for quite a while, and we'll look at some of those factors in a minute. The 2020 data assessment of the 2014 CDC National Immunization Survey found that more than 1/3 of US children between the ages of 19 and 35 months were not following the recommended early childhood immunization schedule. And that's important because even among patients who are accepting of vaccines, and even among those who want to receive them, when you deviate from the schedule and look for alternate schedules, we place at risk our patients, and especially our youngest patients, from delays and maybe eventually not receiving the recommended doses in time to prevent the disease when they might be exposed to the various pathogens. So these next few slides, I think maybe we saw one of these in the last talk, but go through some of the statistics over time in New Jersey. So this first slide looks at the percentage of young children who've received 4 doses of DTaP, a birth dose of hepatitis B, and 4 doses of PCV or pneumococcal vaccine in New Jersey between 2010 and 2020. And we can see that the rates have mostly gone up, with a little bit of a dip between 2016 and 2018, especially for the DTaP and the PCV. What I wanted to tell with this slide, though, more importantly, is that our rates of vaccine acceptance can vary from vaccine to vaccine. And so vaccine hesitancy can be vaccine specific. And we need to know what vaccine we're talking about and what the concerns are with individual vaccines if we're going to counsel people appropriately for the individual shot that we want them to take. This slide looks at percentage of children that have received recommended doses of DTaP, polio, MMR, Hib, Hep B, varicella, and pneumococcal conjugate vaccines. So completed their series between 2010 and 2020. And we can see that New Jersey has dipped in and around the kind of more stable US numbers, but we're right in there in the average in terms of our rates for completion of the series. Although this conference is about children, we know that adults are also asked to accept vaccines. And this graph shows the percentage of adults 65 and above who reported ever having received pneumococcal vaccine. And it's divided up by race and ethnicity. And so again, one of the factors that we need to look at is our population. Who are the people that we're hoping to convince? And we see that rates vary between, for this particular vaccine of PCV, from white, Black, and Hispanic families. And so this kind of information can help us target the populations most at need, as well as help us understand the particular populations that we work with in our local communities and what kind of efforts we might need to do to convince them. And this last one looks at the influenza vaccination rate in the past 12 months for adults 65 and plus by race and ethnicity. And the overall vaccination rate with influenza is typically lower among people in general, but also varies by population. So as I mentioned earlier, vaccine hesitancy is a continuum. A study that was done by Dempsey and others found that even in parents following the recommended vaccination schedule, so these are parents who accept vaccines, and are not even missing doses. 28% of them thought that delaying a vaccine dose would be safer than the schedule that they did ultimately use. And 22% of them disagreed that the best vaccination schedule to follow was the one recommended by the vaccine experts. And so that's a full quarter of our patients that, among those who are accepting of vaccines, who are not so confident that the schedule we recommend is the best one for their child. And we'll look at some reasons for that in a minute too. A combined analysis of the 2018 and 2019 CD National Immunization Survey data showed that about a quarter of a patient's self-report as being vaccine hesitant to one level or another. So it's a large group of patients that we're going to be working with and dealing with pretty much on a daily basis that we need to know how to interact with if we're going to convince at least some and hopefully most of them to accept immunization. So who is vaccine hesitant? It's typically divided into two different groups. There are people who are vaccine hesitant but are under-vaccinated, and they are those who receive some vaccines but not all. That group tends to be our minority population, children of younger mothers with lower income levels in their households living in urban areas. And so this to me says that these are patients who maybe have trouble with access, and they would be willing to accept the vaccines, but maybe because of either lack of opportunity or conflicting priorities, such as needing to go to work, look for childcare, pay attention to other daily problems, they have trouble accessing and achieving the vaccine coverage that they should achieve for their child. And so that's one set of problems that we need to look at. And then there's a population that are unvaccinated, and those tend to be white, children of married mothers with college degrees who live above the poverty level. And these are families that are concerned about vaccine safety. They're more likely to deny all vaccines or very strongly deny specific vaccines for particular concerns that they have related to things that they've learned or read from the internet, social media, family, friends, social groups. And these are the children that are more likely to be covered by exemptions and that are going to be harder for us to reach. So we heard a lot about COVID and other vaccines in the first presentation. I just have 2 slides on that in this talk. A systematic review done on over 548 studies worldwide that included 4 from the United States, included 26 eligible studies in their review, and they demonstrated in 21 of them that there were decreased vaccination rates among children during the COVID-19 pandemic. 3 studies looking specifically at influenza vaccine showed either no changes or increased uptake of influenza vaccine during the pandemic. And I can tell you that that was something that we saw in our clinic as well, that people came in and when I don't know if it was because they thought maybe they had a choice between COVID and flu vaccines, so they decided to take the flu just to take something, or they were concerned about flu genuinely. But we did see an uptake in influenza vaccine during the last couple of years when COVID vaccine was simultaneously being recommended. And then there were 2 studies, one from Brazil and one from Sweden, that showed no significant changes in their vaccination rates. Most of the studies showed that infants and younger children were more affected than toddlers and older children by the problem. And whether that has to do with the number of vaccines that are required and the frequency of vaccine visits that are required in infants may have played a role in the kinds of problems that COVID's brought with quarantines and other concerns that made them more effective. But reasons that parents gave for not vaccinating their children during the COVID pandemic included things like fears of bringing their child into a doctor's office for a well child visit, which they saw as something that was maybe less necessary and not worth the risk, as well as things like social distancing and quarantine mandates that made it more difficult or even impossible at some periods of time for them to attend those visits. Reasons included things like a shortage of healthcare providers who were had open offices and hours available to them, as well as problems with the supply chain and availability of certain vaccines at certain times in different countries. And then again, absence of clear guidelines that made it difficult for providers. And again, this is a worldwide study, made it difficult for them to know what to do and how to do it in the context of a pandemic. Private claims data for 3 routine childhood vaccines, MMR, DTaP, and polio, suggested that an estimated 9 million doses may have been missed in 2020, and an up to 26% drop in those 3 vaccines in January to September of 2021, when this particular article was collecting data. An analysis of 10 state immunization information systems for March to May of 2020, compared with March to May of 2019, estimated a 60% decline in MMR for children aged 2 to 8, and a 60% decline in HPV vaccine for adolescents. And data from the VFC program for 2021 compared with 2019 showed a 21% decline in HPV orders, a 22% decline in Tdap orders, and an 18% decline in meningococcal vaccine orders when comparing those 2 timeframes. And so we have a lot to recover from related to the last few years. Another important factor that relates to vaccine hesitancy that I'm sure we're all aware of and gets a lot of talk, is social media. Social media in its various forms is one of the most important sources of information as well as influence for people as they're trying to think about what they want to do with their families related to health. A 2012 study showed that up to 72% of American internet users trusted the information that they obtained on the internet related to health, and 75% of them evaluated that source of information only sometimes or never. So most people look to the internet to find information, and I think these numbers, if I had to guess, would say have only gone up over time. I even see residents and students when we're making rounds, anytime we ask a question, rather than consulting their mind and what they remember, they quickly pull out their phone and try to look up something quick, usually on Google, and will give a fact related to what they found, sometimes a little bit uncritically, and we need to talk about that. So much more, how much more so for the general public. And a lot of that information that they find is accepted at face value and not questioned. Another thing that we know about social media use is that it tends to reinforce preconceived notions, and the way search engines are designed and the way people use the internet tends to have them reinforce the beliefs that they already have and opinions they've already formed. So people who already mistrust vaccines are more likely to find and believe sources of information that reinforce that belief, and they're sure to find much of that. And conversely, those who are already interested in accepting of vaccines can find information to support that. And it's not so common for people to consider the other point of view. This chart kind of compares key events that went into forming vaccine hesitancy, and the lower part of the screen shows key events in the development of social media, and just kind of gives a time frame for the different platforms that have come into play over the years, including the most recent TikTok in 2016, and then different events in vaccine history, recent vaccine history like HPV vaccine, the H1N1 pandemic, which kind of set the stage for a lot of unconfidence in vaccines. It was played up as something that had the potential to be world changing, and in the end ended up not being such a bad pandemic as most of us remember. The vaccines were much sought after in the early phases of that pandemic when it was announced, but weren't available. And then when the vaccines were available, many people by that time had formed an opinion that they weren't so necessary. And I think that set the stage then for some of what we saw in the COVID pandemic. You can read some of that analysis in many papers that have been written about it in the literature. There's a lot of vaccine misinformation that's available. And among patients who present for vaccines, 18% of them will mistakenly state that it is very or somewhat accurate to say that vaccines cause autism. And that's in the face of decades of attempts to counter that myth. 15% mistakenly agree that it's very or somewhat accurate to say that vaccines are full of toxins. 20% inaccurately report that it's very or somewhat accurate to say it makes no difference whether parents choose to delay or to spread out vaccines rather than relying on the official vaccine schedule. And 19% incorrectly hold that it's very or somewhat accurate to say that it's better to develop immunity by getting a disease than by becoming vaccinated. And many who report low trust in medical authorities in general tend to believe misinformation, but it's true across all demographic groups and across all political beliefs. And so this is one model that was put out by the SAGE group that I mentioned to look at the kinds of influences that we need to take into account when we're dealing with vaccine hesitancy. And so you've got contextual factors like social media, the sociodemographic factors that I mentioned earlier, as well as the leaders, the gatekeepers, and lobbies acting in the background in the population to influence people's opinions. And then in some places, geographic and historical influences and geographic barriers that might be coming into play to inform patients about vaccines and make them more or less hesitant. You've got issues related to the vaccines themselves. So how is the vaccination program in our area designed? And how are we delivering the vaccines? How are we administering them? Is the supply reliable? And the vaccine schedule, is it something that's workable for our patients and families? And here is where healthcare professionals come into play in terms of our ability to influence and instill confidence in the families that we see. And then, of course, there are individual and group influences, things like knowledge about vaccines and vaccine preventable diseases, the risk benefits of vaccines, misinformation that we spoke about, beliefs and attitudes about health in the family and in the individuals themselves, as well as their individual trust in the system, whether it's government, the health system, and the quality of the care that they'll receive within that system. And so understanding these different determinants of vaccine hesitancy is going to go a long way to helping us design programs and conduct individual interventions that will serve our patients well. Excuse me one second, I have to plug in my computer. Okay, so next we'll look at what are some of the major concerns that patients have about vaccines. And so first of all, it can be grouped into issues of safety, necessity, and choice. So based on a 2009 study done by Edwards and Hacknell and reported by the AAP, Committee on Infectious Diseases, in a clinical report done in 2016, 44% of parents reported concern about pain associated with receiving multiple vaccines in a single visit. 34% expressed unease about receiving too many vaccines in a single visit. 26% worried about the development of autism or other learning difficulties related to vaccine reception. And 13% expressed concern that vaccines could actually lead to chronic illness, or that there were not enough testing done to know that vaccines were safe before their use. And so that's a lot of concern about the value of vaccines, the safety of vaccines, and also about the vaccine schedule itself. Some parents are interested in the ingredients of the vaccines, and so we as individual practitioners dealing with patients day to day, as many of us are, should be familiar with what are the ingredients in each of the vaccines that we give, so that when people do have questions, we can provide answers that are accurate, honest, and believable. Some people believe that vaccines are more dangerous than the infectious diseases that they prevent. And this is actually becoming much more common as many of the diseases that we're trying to prevent fade into the background or disappear. As Dr. Fisher mentioned in her opening, Haemophilus influenza was something that was a feared disease among pediatricians. Working in the emergency room at night, dreaded the kid coming in with epiglottitis that you had to deal with, and that could die in front of you. But as many of these diseases that caused a lot of morbidity and death in children have disappeared over the years, and there's less personal experience with it, patients and families tend not to understand the risk, and so look at the risk of the vaccine as being more important. And some families believe that there are toxins in vaccines that can lead to an assortment of chronic health conditions, whether it's things like autism or autoimmune diseases, and that in the end can be more dangerous than vaccine preventable diseases themselves, which they see as rare and not likely to happen to them. Alternate schedules come up often in clinical practice. Parents worry about the number of injections a child might receive at a single visit, either for pain, as I mentioned before, or because they don't want their immune system of the child, quote unquote, overloaded. One study showed that about 22% of parents did somewhat or strongly agree that they were concerned that too many vaccines could damage the child's immune system rather than help it. And a study that evaluated adherence to timely vaccine in children 19 to 35 months found that 40% of them were not adhering to the recommended schedule. And children who follow an alternate schedule were over four times more likely to not be up to date with their vaccines compared to children following the recommended schedule. And so when it comes to an individual patient, we really want to try hard to convince them that following the recommended schedule is really in their best interest. Younger children in particular, the concern about pain is something that you try to talk to the parents about, realizing that a child is not going to know the difference between 1 or 2 versus 3 or 4 shots. They're going to feel pain, but they will react more if they're brought to the office more frequently for that same painful experience. And so to get it all kind of done with quickly is not only safe, but is probably in the child's best interest in terms of protecting them both from pain as well as from potentially not being properly vaccinated. Some parents do believe that getting the natural disease is healthier. Many lack, as I mentioned already, firsthand experience with these diseases, and so it lowers their perception that an infection or severe infection is even likely. Many parents question vaccine usefulness because of this, and the overall success of our U.S. vaccination program has really played its part in furthering this, because these diseases are so rare. It really does allow parents to begin to question whether the vaccines are still needed or not. And the periodic outbreaks that we have recently with measles or pertussis are the kinds of things that we need to recall and bring into the families' minds to help them remember that these diseases, many of them, most of them are not gone. And although they may be unlikely, with enough vaccine hesitancy or vaccine refusal, they can resurge and once again become problems, not only in a theoretical sense, but in a very real sense for them and their children. Some parents believe that there are alternatives to vaccines that are more effective and safer. And so we should become familiar with different alternative therapies that parents might be using in our individual communities, and be able to give them advice as to the safety or harm of those particular alternatives, and whether or not some of them can be used or should be avoided, even in conjunction with giving the recommended vaccine. Based on a 2009 study about parental vaccine safety concerns, 11% of parents strongly agreed that their child doesn't need vaccines for diseases that are not common anymore. And 32% of parents refused varicella vaccine. 32% of the parents who refused varicella vaccine, half of those parents said that they would rather have their child get the disease and develop immunity that way, which they considered a more natural process. And they weren't really aware of the potential complications of a varicella infection that could be suffered by their child. And then the issue of choice and freedom of choice. So some parents endorse or cite the health authorities and government authorities as barriers to vaccine acceptance because they don't trust the authorities for historical or personal reasons. Conversely, local leaders, whether it be religious leaders or other community leaders, can be engaged as effective messengers for motivating parents to vaccinate, as they can serve as sources of information for encouraging families in their sphere of influence not to vaccinate their child. And so often working with local leaders to engage their religious congregations or community groups can be a very effective way of increasing uptake of immunizations. Vaccine refusal has been linked to moral convictions and philosophical beliefs, such as a preference for natural versus artificial medicine. And spikes in vaccine hesitancy often coincide with new information, new policies, and newly reported risks. And so we need to be paying attention to what's making the rounds in social media as well as in the news, and be up to date with our information so that when parents come in with questions or concerns, we can effectively counter them. Vaccine laws are often and increasingly politicized. Every state, as was mentioned in the last talk, does mandate that children receive vaccines prior to enrolling in school, but philosophical exemptions are offered and religious exemptions are offered, as they are here in New Jersey. From a study in 2009, 31% of parents believe that they should have the right to refuse vaccines that are required for school for any reason, religious or otherwise. And eliminating the opportunity or making exemptions more difficult to obtain can be a very effective way of increasing vaccine uptake for children who are school age and need to attend school. So how do we build demand for vaccine or increase vaccine confidence? First of all, vaccines should be accessible and easy to get. People should be encouraged to see them as beneficial, that the health benefits outweigh the perceived risk of getting COVID-19 vaccine or other vaccines. It should be convenient and appealing. It should be something that is seen as a normative process. Most people are going to do what they think is normative for the population where they live. And so the more we can make vaccines something that are seen as something that everybody does, the more likely we are to have higher rates of vaccinations. And we want people to see them as necessary and something that they want to get back to doing. There are various messengers of vaccine information. We mentioned several of them: internet, social media, religious and community leaders, government and health authorities. Family and friends play a large role in vaccine uptake, and so it's important for us to know who are the influencers in the families that we work with. And we as healthcare professionals need to acknowledge that our role is paramount in changing patients' opinions about vaccines and encouraging them to get vaccinated. 80% of parents say that the primary care provider positively influenced their decision to get a vaccine. And 30 to 50% of vaccine hesitant parents agreed to vaccinate their child when they were in an engaged discussion with their provider. And then, as I mentioned in the last slide, making vaccines mandatory for school entrants does increase vaccine uptake. And so we as healthcare professionals are the most trusted source of information on vaccines, and our answers to their questions will help them make informed decisions about vaccines for themselves and their children. And a strong recommendation on our part is probably the single most important thing that we can do as part of the conversation. When we present information, it's important to remember that just providing scientific data is probably not enough. We need to develop a trusting relationship with our families, and using stories and personal examples are usually more effective than quoting statistics. So sharing with families why we vaccinate our own selves or our own family members can make them aware that we're comfortable with the vaccine and help them be comfortable with it. And acknowledging their opinion using motivational interviewing techniques, open-ended questions, and giving a strong advice for them to get vaccinated can go a long way to helping them make that decision. We should lead with listening. So first, we want to understand the individual concerns that that particular patient or family has. Use open-ended questions and respond empathetically rather than critically. So the concerns that patients raise about vaccines are really deeply held by them. And so the more that we can convey that we understand their concerns and are attentive to them, the more they'll come to trust what it is that we have to say about vaccines. We certainly want to correct misconceptions. And so once you have a patient's trust, you can try to understand where they're coming from, but explain the truth about what they are saying if they are under some misconception about a particular vaccine or its utility. And then again, give a clear, strong recommendation that vaccinating their child is the best thing they can do to maintain health. This is an older slide, and it's specifically related to HPV vaccine, but I think it was important because it really speaks to the influence of the strength of a clinician's recommendation on a person's intent to vaccinate. So you can see across the top, it talks about how strongly a practitioner advised either against, neutral, or for a vaccine, or didn't discuss it at all. And then down, it talks about whether a patient will not, is unsure, or didn't know whether they would get the vaccine. And the purple highlights show that among healthcare providers that didn't discuss a vaccine, about half patients then would decide not to get that vaccine. Whereas if it was recommended or strongly recommended, about 35% of patients will receive the vaccine, versus among those who did not offer a strong recommendation, only 11% would get it and about 20% would not get it. So the difference between talking about it versus giving a strong recommendation really does go a long way to influencing our patients' behavior. Our own hesitancy can form a part of what we do and say with our patients. And so it's interesting to see that the 2015 article showed that 5% of healthcare practitioners did not routinely recommend vaccines. 13% of us expressed concerns about vaccine safety, and 31% expressed concerns with vaccine efficacy. And so one of the things that the system, we in the working in the Department of Health at the CDC and other places need to do is reach out to healthcare providers to with education as well as information to increase their confidence in vaccinations, because these providers that are concerned about vaccine safety and efficacy are not likely to recommend them to their patients. One thing that I like to always raise is how we see our parents' concerns. It's important for us to know that any studies show between 55 and 90% of parents and adolescents do follow provider recommendations about vaccines. And particularly with HPV vaccine, which is an area of special interest for me, most parents believe that their sons or daughters will at some point be at risk for STDs. And that this is important because this is one of the points that some providers may be unwilling to want to bring up, especially with younger adolescents. And so we tend not to speak about the things which we think parents don't want to hear about. And so this is true for HPV as well as for flu vaccine. If you look at this graphic, compares in the dark blue bars, the parents' value on a scale of 0 to 10 of each of these vaccines. And the light blue bar shows the provider's estimate of what they think a parent value is for these individual vaccines. And so for vaccines like meningitis, hepatitis, and pertussis, there's great agreement. 9 out of 10 families say they value the vaccine highly, and providers agree and expect that their parents do. But when we talk about things like flu or HPV vaccine in particular, providers think that there's less value placed on those vaccines, whereas parents are not reporting such a difference in the value they place on the vaccine. But providers that believe this are less likely to actually offer and encourage particular vaccines among their patients, because they don't want to have probably a confrontation. So we need to know that parents do value the vaccines and value the information, and we should be talking about these the vaccines in particular that have lower uptake rates if we're going to make a difference. So what are the recommendations? And I'll try to go through these. We want to start early and build trust with our families. Information should be tailored to our target audience. So we need to know what their reasons are for hesitancy and the context in which we work so that our messages can be addressing their particular concerns as well as being culturally appropriate for the patients we work with. One approach that is really proven to be effective is a default approach. So making an assumption that parents will accept the vaccines and presenting it as something that's normative and that everybody should do rather than an option will go a long way to convincing a large proportion of patients that they should get the vaccine for their children. We want to use educational materials that take into account the best practices for health literacy in our families and engage in dialogue so that our communication strategies are open to dialogue, are empathetic and understanding of concerns. Our message should be that vaccines are safe and effective, that the current vaccine schedule is the only recommended schedule for us to follow. We want to utilize that presumptive strategy that I just mentioned and make sure that our message is personalized for the concerns of the individual family that we're working with. Our stories should be emotive. So telling a family about a case of disease or a personal experience rather than scientific facts can be much more motivating to them than just information. We want to engage with other messengers, such as in the community and religious leaders that can help us give information about vaccines and encourage vaccines. And we want to center that on the child and the community. We certainly should be utilizing technology, whether it's social media or email, tablets in our offices, and working with patients, texting to increase vaccines. We want to use caution when addressing misinformation. Sometimes if we're too aggressive with our attack on misinformation, we may turn families off and not engage them in a dialogue. And so we want to tread lightly and try to understand what their concerns are and help them improve really their vaccine literacy and critical thinking skills. Information strategies for communication should seek to inform and educate our families, enhance community ownership of vaccines, teach skills and provide support to our community partners who are working with us to encourage vaccinations in our community and really facilitate good decision-making among our families. And I recommend to you this article by Olson that goes through a lot of information regarding communication strategies that's in the literature that was done very recently for some specifics about all this as you're developing programs. In the short term, we should learn to leverage digital and mainstream media to drive awareness and coordinate between our health and education sectors to increase access. We want to use every opportunity we have, whether it's sick visits, well visits with individual care, as well as opportunities to educate in schools and other community organizations, to encourage routine immunization, and then utilize things like reminder recall, using the vaccine registry, and engaging community partners to increase uptake. In the long term, we want to make sure that our immunization information systems like the NJIIS are workable and are something that provide good quality as well as easy to use information for providers so that they can use this information to reach out to their families and know what their own rates are in an individual practice. We want to mitigate barriers to vaccination, so increase access in terms of venues for vaccination, outreach programs, hours of vaccination availability, and secure enough funding and to help this continue, as well as building vaccine confidence among providers and the public in general. So some strategies on a state level, and I know we're running out of time, would be to increase communication, things like immunization campaigns, engaging pharmacists, particularly with older adolescents and adults, for serving as vaccinators for children of that age group, enforcing school vaccination requirements, and ensuring funding. One last thing I'd like to say is training. So this is a study that was done among pediatric residents. And educational efforts during residency training should provide trainees with comprehensive understanding of the effects of vaccines, as well as knowledge to evaluate vaccine safety. However, only about 48% of US pediatric residents reported receiving training in communication strategies for vaccine hesitant parents. 80% of them requested more education. I think we need to reach out to our future generation, whether it's among physicians, nurse practitioners, public health students who are going to be engaging in the future, and make this a priority in terms of their education. So there's work to be done on many levels. Conferences